Good morning. Today's class is on corticosteroids. We will be focusing mainly on the hormones secreted by the adrenal cortex. So as you know, the adrenal glands comprise of the cortex and the medulla. The hormones secreted by the adrenal cortex include the glucocorticoids, mineralocorticoids and the sex steroids. The adrenal medulla secretes epinephrine and norepinephrine. Now in this class, these learning objectives are to classify the corticosteroid hormones, describe their mechanism of action and their pharmacological actions, followed by adverse effects and uses. Now this is briefly the control and action of the adrenal glands. Hypothalamus secretes or releases the corticotropin releasing hormone, which stimulates the anterior pituitary to release adrenocorticotropic hormone, which then stimulates the adrenal cortex to release the adrenocortical steroids. Now, depending on the blood levels of adrenocortical steroids, there is going to be a negative feedback inhibition. So this comprises the hypothalamo pituitary adrenal axis, or short form is the HPA axis. A word to be noted here is when steroids are administered from outside in large doses, there is no stimulation of the adrenal glands because the exogenous steroid is going to inhibit the hypothalamus pituitary adrenal axis. So the adrenal gland atrophies and does not produce corticosteroids. The classification of the glucocorticoids, they are called glucocorticoids because basically due to their influence on carbohydrate metabolism. The classification is based on both source, potency and route of administration. So we have the natural corticosteroids, namely hydrocortisone and cortisone. Then the synthetic, we have prednisolone, methylprednisolone, betamethasone, dexamethasone. The mineralocorticoids include aldosterone, which is natural, fludrocortisone and desoxycorticosterone acetate. And of course the adrenal androgens or sex hormones. Inhalational corticosteroids, that is those which are used in the prevention of bronchial asthma, include Beclomethasone, Budesonide, Fluticasone, Flunisolide and Ciclisonide. Inhalational corticosteroids is a 5-mark question in a theory paper. Then we have the topical corticosteroids, which include the potent ones, namely betamethasone, beclomethasone, triamcinolone, clobetasol and dexamethasone. Moderately potent topical corticosteroids include fluocinolone, mometasone and flucortolone. Hydrocortisone ointment, very mild topical corticosteroid. Classification can also be done based on the duration of action, but for your purpose, what we just described now: natural, synthetic, inhalational and topical. Now this table gives us the anti-inflammatory activity, salt retaining activity and on topical application their relative potencies. So cortisone and cortisol, which are natural, are taken as 1 and 0.8. You will notice here that fluprednisolone has a potency of 15 compared to cortisol. Betamethasone is a very potent long-acting corticosteroid. Now this table was just to give you an idea about the anti-inflammatory and salt retaining properties of the different corticosteroids. Topical corticosteroid preparations we have already mentioned: hydrocortisone, betamethasone, beclomethasone, dexamethasone, clobetasol, etc. Now coming to the pharmacological actions of corticosteroids. So your 10-mark main question can be: classify corticosteroids, describe their pharmacological actions, mechanism of action, uses and adverse effects. So we will classify them as glucocorticoid action, mineralocorticoid action, and actions on the different organ systems. Coming to the glucocorticoid actions on glucose metabolism. Corticosteroids promote glycogen synthesis and gluconeogenesis, and they inhibit the peripheral utilization of glucose. So the net effect is hyperglycemia. Therefore, corticosteroids are relatively contraindicated in diabetes mellitus. Now what happens to the protein metabolism? Glucocorticoids promote protein breakdown. There is muscle wasting, lympholysis, loss of osteoid tissue of the bone, and thinning of skin. So the net effect is negative nitrogen balance. There is lipolysis with redistribution of fat. What you learn in physiology, the moon face, buffalo hump, those kind of features. On calcium metabolism, the role of corticosteroids is they cause osteoporosis, bone resorption, because of which blood levels of calcium will increase and result in renal calcium stones. Therefore, in the elderly, where there is already a predisposition for osteoporosis, corticosteroids should be used with caution. Now, very important on the stomach. They increase gastric acid secretion, therefore, they can predispose to peptic ulcer. So, one more contraindication for corticosteroids is peptic ulcer and gastritis. On the RBCs and WBCs, there is lympholysis, that is lymphocyte count decreases, RBC count increases, platelets and neutrophils decrease. There is decrease in lymphocyte, eosinophil and basophils with an increase in RBC, platelets and neutrophils. So the net effect of glucocorticoids is immunosuppression. So corticosteroids can be used as immunosuppressants, especially to prevent transplant rejection. At the same time, this immunosuppression can result in superinfections. A very important effect of the glucocorticoids is immunosuppression activity. In addition, all glucocorticoids or corticosteroids are powerful anti-inflammatory agents. All signs and symptoms of inflammation are reduced. So what are the signs of inflammation? That is swelling, localized redness, pain, all these are reduced. Now the mechanism of the anti-inflammatory action of corticosteroids. If you recall from your pathology, whenever there is tissue damage or cell damage, the membrane lipids are acted upon by the enzyme phospholipase, releasing arachidonic acid. And the products of the arachidonic acid via the lipooxygenase and the cyclooxygenase pathway are leukotrienes, prostacyclins, prostaglandins and thromboxane. These are the chemical mediators of inflammation. Corticosteroids inhibit this enzyme phospholipase A2, which is the very first step in the release of the chemical mediators of inflammation. So corticosteroids are very powerful anti-inflammatory agents. Corticosteroids suppress all types of hypersensitivity and allergic phenomena. So there is immunosuppression and reduction in allergic response. This is the basis for use of corticosteroids in organ transplant rejection prevention and in the treatment of autoimmune diseases. Now, because immunity is suppressed, the adverse effect is opportunistic infections. On the cardiovascular system, excuse me, capillary permeability is restricted, tone of blood vessels is maintained, and myocardial contractility is maintained. This is the normal function. In excess, what happens? All these get disturbed. On the CNS, in moderately high doses, there is mild euphoria. In larger doses, it can result in insomnia, anxiety, and depression, and can occasionally cause psychosis. Now these effects are seen only with large doses of corticosteroids. Skeletal muscles. Like we said, corticosteroids cause protein breakdown, negative nitrogen balance. So there is muscular weakness. Corticosteroids are also required for normal muscular activity. So in the presence of excess corticosteroids, there is muscular weakness because of protein breakdown. In addition, there is also loss of sodium and potassium in urine, which contributes to the muscular weakness. The mineralocorticoid action will be increased sodium absorption and increased potassium and water excretion in urine. So the net effect is sodium retention, potassium loss. This results in increased blood volume, therefore increased blood pressure, therefore hypertension. So hypertension is again one more contraindication for the use of corticosteroids. Now the mechanism of action of corticosteroids. These receptors for corticosteroids are present in the cytoplasm. So the corticosteroids passes through the cell membrane, binds to the cytoplasmic receptor. This steroid receptor complex then migrates into the nucleus and binds to specific sites on the chromatin depending on the target tissue, resulting in transcription of specific messenger RNA and therefore the regulation of protein synthesis. Like we have seen, corticosteroids act on almost all the tissues, whether it is the bone, WBC series, RBC series, stomach, in all these places. So this gives an overview of what we just said. So the steroid hormone passes through the cell membrane, binds to the steroid receptor. The steroid receptor complex then moves into the nucleus, binds to specific sites, causing transcription of specific regions of the gene, and new protein is synthesized, which are responsible for the effects of the corticosteroids. Now, any hormone use can be broadly divided into two: replacement therapy and non-replacement therapy. When do we say replacement therapy? That is, when the patient is not producing enough of the said hormone, it needs to be given from outside. So when do we use replacement therapy with corticosteroids? Acute adrenal insufficiency. That is, all of a sudden the patient suffers from a situation where the adrenals are not producing enough corticosteroids. This is a medical emergency. This is also referred to as Addisonian crisis. Then we have chronic adrenal insufficiency, as seen with many of the, it could be either drug induced or it could be due to diseases. Adrenogenital syndrome, also called congenital adrenal hyperplasia, where the adrenal gland is not functioning properly. Now coming to the non-endocrine uses or non-replacement uses of corticosteroids. In arthritis, arthritis is the plural for arthritis. In osteoarthritis, rheumatoid arthritis, and in rheumatic fever. Now this picture shows intra-articular injection of a corticosteroid in very severe osteoarthritis or rheumatoid arthritis involving the knee joint. In acute gouty arthritis, where the corticosteroid is given either systemically or orally. In collagen diseases like systemic lupus erythematosus, polyarthritis nodosa, and nephrotic syndrome. In severe allergic reactions like anaphylactic shock along with adrenaline, and in angioedema. Now in these situations, it is for the anti-allergic and anti-inflammatory effect. In autoimmune diseases, the Immunosuppressive effect of the corticosteroid is used. For example, hemolytic anemia, thrombocytopenia, chronic active hepatitis, and myasthenia gravis. In bronchial asthma, inhaled corticosteroids are used in prophylaxis and also as part of the treatment of severe acute asthma or status asthmaticus, mainly for its anti-inflammatory role. In thyroid diseases like subacute thyroiditis and malignant exophthalmus, here it is the anti-inflammatory role. In eye diseases, locally, that is as eye drops or eye ointment, in all types of conjunctivitis, iritis, iridocyclitis, and keratitis. Corticosteroids are administered systemically in retinitis, optic neuritis, and uveitis. Topical corticosteroids in the eye should not be used in corneal injury and herpes simplex keratitis. In corneal injury, because as you know, the cornea is avascular, if there is suppression of the inflammatory response, the cornea will not heal. In herpes simplex keratitis, because of the immunosuppressive effect of the corticosteroids, there can be secondary bacterial infection of the cornea. Skin diseases like atopic dermatitis, seborrheic dermatitis, xerosis or dry skin, pemphigus vulgaris for its immunosuppressant effect, Stevens-Johnson syndrome for its immunosuppression and anti-allergic effect. In intestinal diseases, especially the autoimmune conditions like ulcerative colitis and Crohn's disease, in cerebral edema, the role of corticosteroids again is questionable, probably for its anti-inflammatory effect. In acute lymphocytic leukemia, Hodgkin's lymphoma, non-Hodgkin's lymphoma, advanced breast cancer, in all these lymphomas and leukemias, because RBCs reduce the corticosteroids reduce the WBC series count. Therefore, they are part of the chemotherapy for leukemias and lymphomas. To prevent organ transplant rejection, the immunosuppressive effect of the corticosteroid is used. Then to promote maturation of fetal lung tissue, especially in a premature infant. The role of corticosteroids in a thyroid storm or a thyrotoxic crisis, like we mentioned in our class on anti-thyroid drugs. The patient who is undergoing a thyrotoxic crisis, there is a possibility of acute adrenal insufficiency. This is a picture depicting Stevens-Johnson syndrome, where corticosteroids are life-saving. Again, same picture. Of Stevens-Johnson syndrome involving the entire skin, whole body. This is an intra-articular injection of corticosteroid in temporomandibular joint, very severe TMJ arthritis. In the treatment of submucous fibrosis of the oral cavity, the corticosteroid is infiltrated submucosally. So in the next class, we will take up the adverse effects of corticosteroids. Thank you.